Welcome to online anesthesia video of the week. Today topic is presented by Dr. VINOTH Kumar, a consultant anesthesiologist, Ganga Medical Center and Hospitals, Coimbatore. He did his undergraduate in Madurai Medical College during 2008 to 2014 and postgraduate in anesthesiology at Institute of Medical Sciences, Banaras Hindu University, Varanasi during 2015-2018. He's done fellowship in trauma and regional anesthesia at Ganga Hospital. He got Best Paper Award in RSACP conference held at Kanpur in 2017. He has so far published 7 papers in international and national publications. Participated as workshop faculty in World Congress of Anesthesia, held in Prague 2022 and in ISA Conference Tamil Nadu Madurai 2022.
A very good morning to one and all present here. Today I am going to talk about basic principles of PNS and newer and emerging concepts. Myself, Dr. VINOTH Kumar SP, consultant anesthesiologist in Ganga Hospital, Coimbatore. Before going into the topic proper, I'd like to thank Dr. Edward Johnson sir and the online anesthesia team for giving me this opportunity. So this is where I work, and it's a 650-bedded tertiary care center dealing with trauma, orthopedic, spine, plastic surgery, and hand and reconstructive unit. We have about 40 operating theaters doing about 125 surgeries per day. And this is our team. We comprise around 80 anesthesiologists in total. And coming on to the topic, what are the modalities for peripheral nerve blockade? So these are the ways in which you can block a peripheral nerve. So way back, we all started with anatomical landmark guided approach, and then by eliciting paresthesia from the patient, and then came the peripheral nerve stimulator, and then ultrasound guided peripheral nerve blocks, and then dual guidance that includes your peripheral nerve stimulator with ultrasound guidance. And there is one more, the last one. Keep guessing, I'll come to that later. Coming on to the introduction, electrical stimulation of peripheral nerves started way back in 1970s. So more quantitative inference of the needle and the nerve, and reduced block failure rates. So the use of anatomical landmarks and haptic feedbacks like pops, clicks, and loss of resistance, and patient-reported paresthesia. So these are the basics of peripheral nerve stimulator. Coming on to the brief history, in 260 BC, there is hollow nerve doctrine that described the nerve as a cavity through which messages travel. Over time, tremendous philosophical speculations was devoted to the mechanism responsible for the transmission of messages through the nerve. In the 18th century, when electricity was accepted as a biological property, electricity became the most tangible means to explain neuromuscular conduction. So these are the histories like Sir Luigi Galvini described the neuromuscular stimulation, and then followed by Perthes, the electrical nerve stimulator, and Kuhlenkamp for describe the brachial plexus block, and so on. And in 2004, Dr. Hadzik and Loka defined the electrical characteristics and suggested manufacturing standards for modern nerve stimulators. Coming on to the basics of neurophysiology and electrophysiology, this is the normal action potential of a nerve. So a voltage potential across the membrane, it varies from -60 to -100 millivolt, and the resting membrane potential is about -70 millivolt. A decrease in the electrical potential difference will lead on to depolarization and firing. So this normal action potential of a nerve is explained in this picture. We'll start from here. The resting state, the activation gates. The activation gates on sodium channel will be closed. So that is the resting state, whereas the inactivation gates will be opened for the sodium channel. This is the sodium channel, this is the potassium channel. So the extracellular sodium cannot come inside since the activation gates are closed. So that is in the resting state. So once depolarization happens, a stimulus opens the activation gates of some sodium channels. Sodium influx through those channels depolarizes the membrane. If the depolarization reaches a threshold, it triggers an action potential. This we all know. So there should be some threshold potential. Once you reach the threshold potential, the action potential starts. Before that, If the threshold potential is less than that, then the action potential will not start. So it's like all or none phenomenon. Then the third step is the rising phase of the action potential. Here, depolarization opens the activation gates of most of the sodium channels, while the potassium channels activation gates remain closed. So sodium influx makes the inside of the membrane positive with respect to the outside. As you can see here, the activation gates open and sodium influx happens. So initially, some of the sodium channels will get open, and eventually all sodium channels, the activation gates opened, so the action potential occurs. Next is the falling phase of the action potential. So the inactivation gates on most of the sodium channels close, blocking the sodium influx. The activation gates on most of the potassium channels open, permitting potassium efflux, which again makes the inside of the cell negative. As you can see here, the inactivation gates closes and the potassium channel opens. So this will permitting the potassium efflux. And then the last is the undershoot. Both gates of the sodium channel are closed, but the activation gates on some potassium channels are still open. As these gates close on most sodium potassium channels and the inactivation gates open on sodium channels, the membrane returns to its resting state. So there is something called current intensity. So it is a measure of stimulus strength. It is the flow of electrical charge used to depolarize the nerve and subsequently produce a motor response or twitch. So it is given by formula Q equal to I into T. So whereas Q is the total charge and I is the intensity of the current, and T is the duration of which it is applied, or the time. So a certain minimum current intensity is necessary at a given pulse duration to reach the threshold level of excitation. So the lowest threshold current at infinitely long pulse duration is called Rheobase. So this is important concept to understand. So there is something called Rheobase and chronaxie, whereas Rheobase is defined as the current. So it is the lowest threshold current required to stimulate the nerve. So at a pulse duration, at the infinite long pulse duration, the lowest threshold current required to stimulate a nerve is called as Rheobase. Whereas the chronaxie is the pulse duration or the pulse width at double the Rheobase current is called as chronaxie. So chronaxie denotes the time, whereas Rheobase denotes the current. So for easily remember, you can remember CT as computer tomography. CT is for C for chronaxie, T for time. So chronaxie in order to avoid confusions. So I used to remember like this only. So the pulse duration or the pulse width at double the Rheobase current is called as chronaxie. So this you can see in the graph. So this is the Rheobase. Rheobase at an infinitely long pulse duration. So this is the pulse width. So at an infinitely long pulse duration, this is the minimal current required. So the x-axis denotes the stimulus duration and the y-axis denotes the stimulus amplitude. And this is the chronaxie at twice the Rheobase. This is the Rheobase, so this will be twice the Rheobase. The time required for twice the Rheobase of current is the chronaxie. So this will be the chronaxie. So nerves have same Rheobase, but chronaxie varies. Again, this is also important. So as you can see, so how to elicit a painless motor response? So to achieve sensory motor differentiation, so appropriately lower the current intensity and maintain the strength of elicited muscle contractions. Withdrawal and reposition of stimulating needle should be minimal. So while we generally use a peripheral nerve stimulator, there will be N motor response. You will get twitches, but the patient will not have pain. For this, there is a sensory motor differentiation. So because the chronaxie varies for motor nerve and for the sensory nerves, the chronaxie varies. So chronaxie value provide an indicator of the relative excitability of a nerve. So for A alpha fibers or motor fibers, the chronaxie is very minimal, that is 0.05 to 0.1 milliseconds. Whereas for A beta, A gamma, like touch and pressure sensations, and A delta fibers for pain and temperature, and B fibers, the chronaxie will be 0.15 milliseconds. Whereas for C fibers, which conduct slow pain, is 0.4 milliseconds. So by this we can differentiate so that the patient will not have a pain during the motor response. So this is explained in this picture. Like this is the normal nerve fiber axon with insulation, that is a myelin sheath. You can see this is the myelin sheath and this is a node of Ranvier. This the A alpha fibers or the motor fibers. So A alpha fibers, motor fibers will have high speed of impulse propagation, that is called as saltatonic spread of excitation. So here the like your sodium will jump from this, from one node of Ranvier to another node of Ranvier. So the speed of impulse propagation will be more, will be high speed. That is called as saltatonic spread of excitation. So here the chronaxie will be 0.1 milliseconds. So as I told, this is A alpha motor fibers. This is a nerve fiber, and this is the another nerve membrane. Whereas here is the unmyelinated C fibers. Since it's unmyelinated, the low speed of impulse propagation, so it is called continuous spread of excitation. And here the chronaxie will be 0.4 millisecond. Actually, this is wrongly typed. It's 0.4 milliseconds. So this is the nerve fiber or axon without insulation. That is like without myelination. That is the pain fibers. So schematic anatomic structure of nerve fibers is shown here. So coming on to the action potential difference between the motor nerve fiber and the sensory nerve fiber. So the motor nerve fiber, the depolarization occurs immediately, as you can see here. Whereas here the depolarization takes more time in a sensory nerve fiber. And then the threshold level reaches, and then the firing and action potential happens. Coming on to the frequency, frequency is defined as the number of repeating events per unit of time. 1 or 2 hertz is the optimal for nerve localization. 1 hertz is used when pain due to muscular movements is to be avoided. When using 1 hertz, needle must be advanced very slowly to avoid missing the nerve. 2 hertz allows faster needle manipulation and hence commonly used. 3 hertz is also available, that is called as sense, that is sequential electrical nerve stimulation. Use of higher frequencies causes greater discomfort to the patient, while in low frequency there is a risk of nerve penetration and injury. So it is important to understand whether to keep 1 hertz or 2 hertz. Usually we keep 2 hertz, that is the most commonly used. 1 hertz you can keep when the more muscular movements is to be avoided. That can lead on to discomfort or pain the patient can happen. So pulse width. Pulse width is the duration of time to which the current intensity is applied. Depends on chronaxie of the nerve. So short pulse width like 0.1 millisecond corresponds to chronaxie of A alpha fibers, more suitable for nerve stimulation, that is the motor nerves. And the longer pulse width like 0.4 milliseconds and all, if you keep, that is to elicit paresthesia in awake patients to block sensory nerves. So it is like commonly we think that with using peripheral nerve stimulator we can block only motor nerves. It is not like that. Even you can block a pure sensory nerve like lateral femoral cutaneous nerve using peripheral nerve stimulator. There you have to once the needle is near the nerve, you have to elicit paresthesia from the patient. So for that you need a larger pulse width or the duration, that is 0.4 milliseconds, and compared to 0.1 milliseconds for the motor nerve. And also if the patient is having any diabetic neuropathy or polyneuropathy, again you have to use a larger pulse width. Coming on to quality of stimulation, it is influenced by number one is polarity and type of electrode, and then the distance between the stimulating needle and the nerve, and then the interactions at tissue needle interface, that is called as the impedance. Coming on to the polarity, like cathode, the negative electrode should be connected to the stimulating electrode needle, that is, and then the anode positive electrode should be connected to the patient's skin, that is a returning electrode. So cathode will have less current intensity required, and the negative current emitted from the cathode reduces the voltage gradient around the neuronal membrane, which causes depolarization and generation of action potential. So as you can see here, if cathode is stimulated, you can have a action potential motor response. Suppose if there is an anode stimulation causes hyperpolarization and decrease in the excitability of the nerve. So since the negative current is emitted here, it reduces the voltage gradients from the neural membrane, whereas here the positive current is emitted, so it lead on to hyperpolarization. And remember, the negative is connected to the needle, so NN. So negative electrode to be connected to the needle, and the anode positive electrode to be connected to the patient. So that is P for P and N for N. Avoid current route across heart in patients with pacemaker. Okay. And the negative pole will be black in color and positive electrode will be red in color. and the positive electrode identical will be attached to the patient through an ECG electrode. As you can see here, this has to be connected to the patient through an ECG electrode, and this black, it has to be connected to the needle, stimiplex needle, or stimulating needle, insulator stimulating needle. Coming on to the distance current relationship, the relationship between the threshold current and the distance from the nerve is governed by Coulomb's law. It is like I equal to K into Q by R square, whereas I is the stimulus current required and K is a constant. Q is a minimal current and R is the distance from the nerve. So on rearranging this equation, it will be the minimal current Q is directly proportional to the distance from the nerve. So that you can see in this picture. So here the distance from the nerve and the needle is very minimal. So this means that even minimal current is required for stimulation of the nerve. Whereas if the needle is far away from the nerve, you need more larger current to stimulate the nerve. So that is directly proportional. Distance to the nerve and current intensity relationship. The threshold current is the lowest current which produces a motor response. A value between 0.2 to 0.5 milliampere has been suggested to ensure a successful block. So if you are getting a motor response less than 0.2 milliampere, that means your intraneural, your injection is intraneural or intrafascicular. So there is something called next is impedance, complex resistance. Electrical circuit impedance can be in the nerve stimulator, the nerve block needle and its tip design, then the tissue characteristics of the patient, the skin electrode or the grounding electrode or the cables connecting all the elements. So the resistance of this circuit is not just a simple Ohm's resistor equation because of the specific capacitance of the tissue, the ECG electrode to skin interface and the needle tip, which influence the overall resistance. The capacitance in the described circuit varies with the frequency content of the stimulation current, and it is called impedance or a complex resistance, which is dependent on the frequency content of the stimulus. Dependent on the frequency content of the stimulus, the shorter the impulse, the higher its frequency content, the lower the impedance of the circuit with a given capacitance. Conversely, the longer pulse duration has a lower frequency content. Factors affecting impedance are the impedance of the needle tip, the geometry, and the insulation is a conductive area. So suppose if you use a normally, previously when we do our PG days and all, we use our Venflon needle. Venflon needle is like, it's non-insulated. So the current dissipates everywhere. So that is the conductive. So conductive area will be more. So there will be more false positives when the stimulation happens from the needle shaft and all. That's why it is always better to use an insulated needle where the tip alone is non-insulated and through the shaft and all will be insulated. So the current will not be conducted through that. And then the electrode to skin impedance vary considerably between individuals. Example, type of skin, hydration status, and can be influenced by the quality of the ECG electrode also. What is electrical nerve stimulation? So low intensity, it is up to 5 milliampere current, and shorter duration 0.05 to 1 millisecond. Is a range, total range of pulse width is between 0.05 to 1 millisecond, and 1 to 2 hertz repetition rate of frequency. And defined response is the muscle twitch or sensation, whichever we are stimulating, either motor nerve or sensory nerve. And injecting local anesthetic in close proximity to the nerve to block nerve conduction for surgery. Electrical nerve stimulation can be used for single injection technique as well as for guidance during the insertion of continuous nerve block catheters. The use of nerve stimulation can recognize an intraneural or intrafascicular needle placement and prevent further needle advancement intraneurally and help reduce the risk of nerve injury. This is very important. So this is a major purpose of using a peripheral nerve stimulator. And ultrasound guidance in combination with nerve stimulation is dual monitoring has become a common practice to guide needle placement and robust medico-legal documentation of nerve block procedures. And the other commonly like when we use dual monitoring is for deeper blocks like lumbar plexus, sacral plexus and all. With only ultrasound, it is sometimes it will be very difficult to find the nerve when in obese patients especially and all. So in that case, if you use a peripheral nerve stimulator dual guidance, you'll have both, you can look for the desired motor response. Coming on to the parts of the peripheral nerve stimulator. So as you can see here, this is the screen displaying the set and delivered current and other features like frequency, duration of stimulus will be displayed here. And this is usually an LED display or LCD display. And these are the buttons like to choose to alter current, duration of stimulus, and the frequency. Frequency can be adjusted during using this Hertz button, and MS is the pulse duration or the pulse width, and MA is the current required. So all these can be adjusted using these buttons. And 3 is here, this is the on-off button, and then this will be the dial to increase and decrease the settings. And this, as I already told, this will be the black colored cathode which is connected to the needle, and this is the red colored anode terminal which is connected to the ECG electrode placed to the on the skin of the patient, remote from the site of needle insertion. So this is the parts or of the peripheral nerve stimulator. So there will be a microcontroller and controls which controls a microcontroller, and then the clock reference display and the constant current generator. So the constant current generator is the most important feature of the peripheral nerve stimulator. So constant current generator provides a stable current over the clinically expected range of impedance, generates progressively higher voltage output as the impedance between the electrodes is increased. And then the controls for amplitude, current, frequency, and pulse width, analog or digital type, increases or decreases the values. Newer machines have a hand controller or a foot pedal as a control to adjust the current. It allows single operator to perform nerve block independently. Usually we need two operators, one for needling and the other one to adjust the currents in the peripheral nerve stimulator. Suppose if we have a foot pedal or a hand controller, so even a single person can perform the block independently. And then the display, usually as I told, it will be a LCD display or LED display. Show set values of current, frequency, pulse width, low battery level, and probe disconnection. Newer machines even display circuit impedance in kilo ohms. Microcontroller is the brain of the nerve stimulator. It runs on battery power DC current and receives input from the controls, changes the value of current, frequency, and pulse width, relays the set value to the display. So this is a digital PNS and this is the analog PNS, and this is the hand and foot pedal operated PNS. And these are the display. What are all the things showed is the stimulus in milliampere, stimulus amplitude milliampere. It is showed in yellow color. This is shown here, and then the pulse width is shown in orange color in milliseconds. That is 0.1 milliseconds commonly kept. And frequency, 2 Hertz frequency is kept in red color. It is depicted, and then impedance in kilo ohm. Here it is marked as 1 kilo ohm here. Okay. Coming on to the needles, there are two types of needles, as I told, insulated needles and non-insulated needles. Insulated needles will have Teflon coated with uncovered plastic tip and maximum current density at the tip. The position of the tip correlates accurately with the target. As I told, these are the insulated needles. So only the tip will have a maximum current density. So it can be correlates accurately with the target. Whereas these are non-insulated needles, stimulation can occur everywhere. As it is shown here, the stimulation can occur everywhere. Shaft of the needle will have false positives and dissipation of current happens. So the stimulation current required will be higher for non-insulated needles, as you can see here. Whereas the coated needles will have very less current. As you can see, only 1 milliampere, less than 1 milliampere is required actually. So it will be more precise. Here you need more than 6 milliamperes for bare uncoated needles. Since there is dissipation, you need more current for stimulation of the particular nerve. Coming on to the bevel, there are short bevels and long bevels. Long bevel is 14-degree, increased risk of penetration and decreased appreciation of facial planes will be there. There are short bevels will have 45-degree angle and decreased risk of nerve penetration. The stimiplex needles which we use will have a bevel of 30 degrees. And blunt needle is preferred because better feedback when penetrating the facial layers, like pops, it can be better felt when you use a blunt needle rather than a sharp needle. And the disadvantage is increased risk of overshoot resulting in nerve damage. And gauges, like larger gauges, increased risk of nerve injury and hematoma, and smaller gauges will have increased risk of intrafascicular placement, increased resistance to injection of local anesthetic, and increased time for aspiration on blood if the needle is intravascular and bends easily. These are the stimiplex A and stimiplex G needles. Again, here In stimiplex ear needles, the tip will be uncoated. So coated needles, shaft will be coated, the tip is the bevel will be uncoated on stimiplex A and contiplex A, and also it needs a little bit higher current, whereas in stimiplex G needles, only the fully insulated needle with the bare tip, only the tip is alone, it's like uncoated. So we'll have even more precise localization of nerves, and the current required will be even more minimal. So as you can see here, only this tip alone is uncoated. Here the entire thing will be uncoated. Stimiplex D plus will avoid its advanced dual guidance is used and outstanding visibility on the USG screen due to a newer laser-based marking technology. So it is like echogenic needles we have. So dual guidance used for both peripheral nerve stimulator and echogenic needles. So the ultrasound visualization also will be better. Moving on to the operating the peripheral nerve stimulator. Pre-check includes a nerve stimulator specifically manufactured for nerve blocks, and insulated nerve stimulation needles are mandatory, and high quality skin electrodes with a low impedance. Some lower priced ECG electrodes can have too high impedance or resistance. And before starting the procedure, check for the proper functioning of the nerve stimulator and the connecting cables. During the procedure, check frequently to assure that the current is being delivered and leads disconnect does not occur. The design of the connector should prevent a faulty polarity connection. So connect the nerve stimulation needle to the nerve stimulator, which should be turned on, and set the current amplitude and duration to the desired levels. For superficial blocks, current of 1 milliampere as a starting current intensity. And for deeper blocks, you can keep 1.5 milliampere as a starting current. And select between 0.1 and 0.3 milliseconds of current duration for most purposes. So usually we use 0.1 millisecond if it is a motor nerve. With ultrasound guidance, select the current as 0.5 milliampere. However, when unexpectedly elicited, it warns the operator that the needle is in the immediate vicinity of the nerve or intraneurally placed. Too high current intensity will lead on to direct muscle stimulation or discomfort for the patient, and that is undesirable. So when muscle response is obtained, current intensity amplitude is gradually reduced. The needle is slowly advanced further. Suppose if we get a response at 1.5 milliampere, then slowly reduce the current, and then gradually push the needle further inside. So only like either of one has to be done at one time. So don't simultaneously push the needle and simultaneously reduce the current. So do one at a particular time. So desired motor response is achieved with a current of 0.2 to 0.5 milliampere at 0.1 millisecond stimulus duration. So the threshold level and duration of the stimulus are interdependent. In general, a short pulse duration is better discriminator of the distance between the needle and the nerve. If motor twitch is lost during needle advancement, stimulus intensity increased to regain the muscle twitch. Needle close enough to the nerve at around 0.3 milliampere current amplitude and 0.1 millisecond pulse duration. 1 to 2 ml of local anesthetic is injected as a test dose using low opening injection pressure, which abolishes the muscle twitch. This is called as a Raj test. The highly conductive injectable like local anesthetic or normal saline solution is injected. Like it short circuits the current to the surrounding tissues, effectively abolishing the motor response. So once you get the response, the desired motor response at 0.3 milliampere, you're getting the end motor response, and you're injecting 2 ml of local anesthetic. Immediately, the moment you start injecting, the muscle twitch will be abolished. So this is called as Raj test. This happens because of the dissipation of the current, and that is nothing but short circuiting. So the current dissipates. Since these are the highly conductive solutions like sodium chloride solution or local anesthetic, highly conductive solutions, there will be dissipation of current that lead on to abolition of the muscle twitch. In such situations, increasing the amplitude may not bring back the muscle twitch. Then the total amount of local anesthetic appropriate for the desired nerve block is injected. So absence of motor response with a stimulating current of up to 1.5 milliampere does not rule out intraneural needle placement. So that's called low sensitivity. So it's very, very important. So if there is an absence of motor response with a stimulating current of up to 1.5 milliampere, it does not rule out intraneural needle placement. However, the presence of motor response with a low intensity current like less than 0.2 milliampere and 0.1 millisecond only with intraneural and possibly intrafascicular needle placement. So it is high, the specificity is very high. You are getting a motor response if with less than 0.2 milliampere, definitely you are intraneural. This called there's something called SUI test also. SUI test is nothing but non-conducting solutions. If you inject, once you get the desired motor response like dextrose or D5 water and all, it decreases the conducting area, increases the current density, and motor response is same or augmented. So here, if you inject a D5 water like here, so only the decreasing the conducting area, so increase current density, and the motor response is same or augmented if you use a D5. Whereas if you use saline or local anesthetic, the increasing the conducting area, as you can see here, and dissipation of current happens. The current reaching the nerve will decrease. Here, the current reaching the nerve will be same or it will increase actually. But here, the current reaching the nerve will be decreased, so there will be no action potential, and the muscle pitch is decreased. So this is called as Raj test, and SUI test is also very important. And coming on to safety precautions to avoid patient discomfort, do not use longer stimulus duration more than 1 millisecond. So avoid too high stimulating currents also. And needle should not be advanced too fast. It will lead on to increasing the risk of injury. The best needle position producing a good near threshold motor response may be missed. Do not inject local anesthetic at exceedingly high pressures. So this picture shows like here, this one is the stimulation needle at a distance to the nerve and high stimulus current eliciting a weak motor response. It is the stimulate needle is at a distance from the nerve. So if with a high stimulus current eliciting a weak motor response. So in picture B, it is the stimulation needle close to the nerve and high stimulus current eliciting a strong motor response. Whereas in C, it is the stimulation needle close to the nerve and low near threshold stimulus current eliciting a weak motor response. So coming on to the troubleshooting, suppose the nerve stimulator does not work at all, then check and replace battery, refer to operator manual. Nerve stimulator suddenly stops working, check and replace battery. No motor response is achieved despite the appropriate needle placement. Then look for check connectors, skin electrode cables, and stimulation needle for interrupted circuit or too high impedance. Check and make sure that current is flowing, no disconnect indicator on the stimulator. Check the setting of amplitude and impulse duration. Check stimulator setting. Some stimulators have a test mode or pass mode, which prevents current delivery. Motor response disappears and cannot be regained even after increasing stimulus amplitude and duration. Suppose if this is happening, then check for the causes listed previously and can be caused by injection of local anesthetic, as I already told. Characteristics of modern nerve stimulators. The electrical features are an adjustable constant current source with an operating range of 10 kilo ohm minimally output load impedance, and ideally at 15 kilo ohm or greater. Adjustable stimulus amplitude 0 to 5 milliampere, that is the range. Large and easy to read digital display of accurate actual current delivered. So this also will be displayed in the monitor. Suppose if you kept a current of 1.5 milliampere, but if the actual current delivered is 0.5 milliampere only, that 0.5 milliampere will be displayed in the screen. A selectable pulse duration or pulse width at least between 0.1 and 1 millisecond. Motor fibers are stimulated more easily with currents of shorter duration, whereas sensory fibers require a longer stimulus duration. This I told in chronaxie. That is the concept of chronaxie. A stimulus frequency between 1 and 3 Hz, meaning 1 to 3 pulses per second. The best compromise is 2 Hz, which should be default. Safety features are easy to use, a large and easy to read display, limited current range because an amplitude that is too high may be painful or uncomfortable for the patient. A display of all relevant parameters such as amplitude, charge, stimulus duration, stimulus frequency, impedance, and battery status. Clear identification of output polarity, negative polarity at the needle, and meaningful instructions for use with a list of operating ranges and allowed tolerances. Alarms or warnings. It will show an alarm if there is an open circuit or disconnection alarm. Warning or indication if impedance is too high, that is the desired current is not delivered. Displaying actual impedance is advisable. Near threshold amplitude indication alarm, low battery alarm, and internal malfunction alarm will be there. Coming on to the newer and emerging concepts, there is something called transcutaneous nerve mapping or surface mapping. This is for percutaneous electrical nerve stimulation. It is a non-invasive technique for localization of peripheral nerve to facilitate block. Longer stimulus duration is used up to 1 millisecond. Transcutaneous pen will be there, as you can see here. The conductive tip diameter should not be larger than approximately 3 millimeter to provide sufficient current density and spatial discrimination, which may not be the case with larger tip diameters. So with this, you can transcutaneously you can look for the desired response and mark the anatomical location of the nerve in the skin. Several kinds of sensation due to stimulation of various sensory cells in the skin. So it can have tingling, a pinprick, or even a slight burning sensation happens. And however, the amount of energy delivered by the nerve stimulators with a maximum output of 5 milliampere at 1 millisecond pulse duration is far too low to create any injury to the skin or the nerves. So it is very safe. And moderate pre-medication might be necessary. Uses or difficult anatomy when ultrasound is not used on teaching surface anatomy. Transcutaneous nerve stimulation, nerve mapping, plus nerve block needle guidance. A small aiming device is mounted and locked onto a conventional nerve block needle, which allows the conductive needle tip to make contact with the skin without scratching or penetrating the skin. The technique allows for pre-location of target nerves prior to skin puncture. Coming on to sense technology, this is called a sequential electrical nerve stimulation. So it incorporates an additional stimulus with a longer pulse duration after 2 regular impulses at 0.1 millisecond duration, creating a 3 Hz stimulation frequency. The third longer impulse delivers more charge than first two and therefore has a longer reach into the tissue. Consequently, an evoked motor response often is elicited at 1 Hz, even when the needle is distant from the nerve. Once a needle tip is positioned closer to the nerve, muscle twitches are seen at 3 Hz. The advantage of sense technique is that a motor response is maintained even when the twitches previously elicited by the first 2 impulses are lost due to slight needle manipulation. So this Stimiplex HNS 12 monitors peripheral nerve stimulators will have the sense technology. So for providers that want advanced peripheral nerve stimulation, ease of use, and greater procedural facility. So sense technology basically uses 3 pulses. So 2 will be of short pulse duration, 0.1 milliseconds. The third will be of longer duration. As you can see here, these 2 are shorter pulse duration. Third will be of longer pulse duration. So that have frequency of 3 Hz. So advantages to get the first twitch sooner for faster visual feedback with sense and large display. So even if the nerve is far away from the nerve, you'll get a motor response. That is the major basic advantage of using sense technology. So it is like in PNS, you're having a GPS tracker or something, so that you can you'll have an idea that your direction of the needle or angulation of the needle is correct only or towards the nerve only. So even if it is far away from the nerve, you'll get a stimulation since the third impulse is of longer duration. You'll get a desired motor response. So from the alternating sequence of 3 impulses, the third longer impulse stimulates the nerve already at a distance. One muscle twitch is visible and indicates that the needle is directed to the nerve. The stimulation needle is further advanced towards the nerve with sense maintains a motor response. Current strength adjustments lead to definite reductions of the third impulse. At the threshold level of approximately 0.3 milliampere, not 1 but 3 muscle twitches are visible as all 3 impulses elicit a motor response. Thus, sense allows easier and more reliable nerve localization for better blocks. If the muscle twitch has been lost, the third longer impulse helps to easily find it again. So these are the stimulating needles which we have already seen, and these are the nerve locator needles. Now needle gauge can be small or large insulation, non-insulated needles. Needle tip design, short beveled or long beveled. Needle length, small or large. Usually for superficial blocks, we'll use 50 millimeter needles, and deeper blocks we use 100 millimeter Stimiplex needles. And then echogenic needles are also available. Needle length depends upon the depth of the target nerve to be blocked, and ultrasound determines the distance and the required length. Marking determine depth of penetration. Echogenic systems for better visualization under ultrasound guidance. Laser reflectors into needle of Stimiplex or Contiplex series, and or can be wire reinforced catheters with radio contrast material at distal tip. So these are the needles, various types of needles. And then coming on to the continuous peripheral nerve blockade, advantages are superior analgesia, less opioid-related nausea, vomiting, respiratory depression, prolonged intra-op analgesia, avoids epidural infusion-related urinary retention, pleuritis, mobility restriction, etc. And associated sympathectomy will be beneficial in microvascular surgeries and free flap surgeries, and prevents development of chronic pain, helps in palliation of terminally ill patients, and continuous peripheral nerve blockade decreases the incidence of phantom limb sensation in amputated patients. So there are various types of continuous catheters, like multi-orifice catheters will have closed distal end, side ports at 0.5, 1 and 1.5 centimeters on the tip. Better spread of injected in manual bolus doses, same in low infusions. Large nerve and plexus aphaseal blocks, these catheters can be used. And single orifice catheters will have open distal end, and non-stimulating catheters will have used for primary and secondary injections, and stimulating catheters is used for secondary injections. Non-coiled or coiled catheters and echogenic or non-echogenic, and King 2 for non-King resistance catheters are also available. Coming on to the catheter through needle versus catheter over needle. So again, it can be of two types. Either, as you can see, this is catheter through needle. Catheter will be inside the needle like this, or can be catheter over the needle. This is the needle, and outside will be the catheter. Stimulating catheters developed as a tool to assess the proximity of the catheter tip to the nerve and to prevent secondary block failure, require a low amount of local anesthetic when compared to non-stimulating catheters, associated with lesser usage of opioid supplementation. The primary block is nothing but, here is written, so primary and secondary injections. So the primary block is nothing but, suppose if you are stimulating with the insulated stimuplex needle that and giving a local anesthetic, that is the primary injection, and secondary injection is giving injections through the catheter, that is called as secondary injections. So if you use stimulating catheters, the secondary block failure you can prevent. Suppose if the non-stimulating catheter, the catheter can get displaced after your placement, so there can be secondary block failure even after injection of local anesthetic. So to prevent secondary block failure, if you use stimulating catheter, so even before injecting local anesthetic, you can stimulate again and see for the desired motor response. So it functions like insulated needles, and there will be a body with insulating body, usually contains metallic wire inside. It conducts the current to the exposed tip electrode, placed using a continuous nerve block needle by first using nerve stimulation, acts as an introducer needle for the catheter. Now, once needle is placed close to the nerve or plexus to be blocked, the stimulating catheter is introduced through it, and the nerve stimulator is connected to the catheter. Reconfirm the threshold current with stimulating catheters can be used. These are the continuous peripheral nerve block catheters and sets. Coming on to the injection pressure monitor, there are like so many modalities. One is B Smart, Nerve Guard, Saphira, and Smart Needle. B Smart, it indicates the open injection pressure. The information is conveniently displayed by the color-coded pressure ranges on the piston. Needle placed perineurally will be less than 15 psi, and high opening pressure, needle nerve contact or intrafascicular needle placement. Suppose if it is more than 20 psi and all with high opening injection pressure, it indicates your needle is intraneural or intrafascicular needle placement. So the ideal thing should have less than 15 psi needle placed perineurally. Again, this nerve guard, again, it prevents intrafascicular injection in case of excessive pressure. Automatically blocks injection when injection pressure exceeds the limit value. Suppose if the injection pressure exceeds more than 20 psi, it will not be able to inject the local anesthetic. So there is a one-way valve here. So it automatically blocks injection. Only if it is less than the desired value, you can inject the local anesthetic. It's called nerve guard. And Saphira is the safer injection for regional anesthesia. 1% procedure, controls injection pressure and allows for foot or hand controlled aspiration and injection. Device consists of battery powered injection pump, place holder for a syringe, and a remote foot controller. Device halts the injection when the pressure is high, that is more than 15 psi. Smart needle is disposable sensing needle. The whole system is composed by the smart needle, the control unit, and the visualization software. The smart needle is connected to the control unit via the flexible optic wire cable coming out from the hub of the needle, and the software allows real-time visualization and recording of injection profiles. Coming on to the role of peripheral nerve stimulator in ultrasound era. With the widespread adoption of ultrasound guidance in the 21st century, the needle could now be observed approaching the target in real time to improve block safety and effectiveness with ultrasound. So these are the few studies where they peripheral nerve stimulator versus ultrasound guided peripheral femoral nerve block for knee arthroscopy procedures, randomized control trial. So they found that both techniques have equal efficacy concerning the duration of the effect of block and patient satisfaction. However, the procedural time and number of needle repositioning were significantly less in the group where ultrasound was used for the block. So this is the major advantage of using ultrasound. So mainly the patient satisfaction, the number of needle manipulations and all will be minimal. Whereas if you use a peripheral nerve stimulator and you are not getting a desired motor response, you will keep on redirecting the needle. That will be uncomfortable for the patient. A systematic review and meta-analysis of ultrasound versus electrical stimulation for peripheral nerve location blockade. So we systematically reviewed the peripheral nerve blockade guided by ultrasound versus electrical stimulation. So this study showed includes 26 comparisons in 23 randomized control trials. So they found that ultrasound reduced the rate of pain during the procedure. Ultrasound with or without electrical stimulation reduced the rate of analgesics or analgesic rescue versus electrical stimulation alone. And the rate of rescue was unaffected by the addition of electrical stimulation on ultrasound. And ultrasound with or without electrical stimulation reduced the pool rate of vascular puncture. And there was no difference in the rate of post-operative neurological side effects. Coming on to the role, as I told, if you use a PNS, there will be double confirmation. So even though you're seeing a nerve in the ultrasound, as I told, especially if the nerve is located deeper and all, you can use dual guidance with ultrasound and peripheral nerve stimulator so that you can have a double confirmation also, and safety, as I told, to prevent intraneural injections if you use only ultrasound. So if you use PNS, you'll have a safety margin of like 0.3 to 0.5 milliampere. You're getting an desired motor response. You can safely inject the drug, and simultaneously, like, you should not get a desired motor response less than 0.2 milliampere. Suppose if you get your intraneural and your needle has to be slightly withdrawn, and then you can inject the local anesthetic. And then obviously for teaching purposes, you can have peripheral nerve stimulator role. So this is an algorithm for use of nerve stimulation when ultrasound guide and nerve blocks. So please note the nerve stimulator here is used primarily as a safety monitoring tool rather than a nerve localization tool. The stimulator is set at 0.5 milliampere, 0.1 millisecond, and the current is rarely manipulated. Instead, no motor response is obtained. Extra caution is exercised as this indicates an intimate needle-nerve relationship. Instead of adjusting the current intensity to determine at which current the motor response extinguishes, the needle is slightly withdrawn to abolish the response. And the distance the needle tip from the nerve, a small amount of local anesthetic is then injected to determine the needle tip location while avoiding an opening pressure greater than 15 psi. So this is the flow chart. Like, so connect a needle to nerve stimulator, 0.5 milliampere, 0.1 millisecond pulse width, 2 Hz frequency. These are the standard settings. And advance needle towards the nerve or plexus. You're using ultrasound also here. So suppose your needle adequately placed seen on the ultrasound screen and twitch is present. So reposition the needle present and the twitch present at less than 0.5 milliampere. So 1 to 2 ml of injection of local anesthetic results in adequate spread in the desired tissue plane, and the opening injection pressure is less than 15 psi. So everything is seen. So this is called as the triple guidance. Both dual guidance is both PNS and ultrasound, and if you use injection pressure monitoring also, that becomes triple guidance. So you can see the desired motor response less than 0.5 milliampere, and in ultrasound also you have seen the local anesthetic spread in a desired tissue plane and open injection pressure less than 15 psi, then complete the injection. Suppose on advancing needle tip towards a nerve or plexus, the needle adequately placed as seen on the ultrasound, but there is no twitch, means then 1 to 2 ml of injection of local anesthetic results in adequate spread in the desired tissue plane, and opening injection pressure is less than 15 psi, then it is not always necessary to look for the twitch. Then I can complete the injection. Even if there is no twitch, but you are seeing adequate drug spread in the desired tissue plane and opening injection pressure less than 15 psi, you can complete the injection. Suppose on advancing needle towards a nerve or plexus, there is needle placement by ultrasound is uncertain, poor images of anatomy on needle, and if suppose if the twitch is present, then you can complete the injection if the opening injection pressure is less than 15 psi, and you can getting the response at less than 0.5 milliampere. Suppose if there is no twitch, again increase current to 1.5 milliampere, adjust the needle placement by ultrasound. Again, if there is no twitch also, but you are seeing desired tissue plane drug spread, you can very well inject the drug if opening injection pressure is less than 15 psi. So this is the triple guidance which I was talking about. This is the injection pressure monitoring, and this is the ultrasound, and this will be the peripheral nerve stimulator. So this is the recommendation nowadays for preventing nerve injury. So a sound knowledge of anatomy and clinical knowledge, and then well practice and experience is required for mastering regional anesthesia. Stop before you block. This is also important. It is a notice for anesthetists and all anesthetic assistants. A stop moment must take place immediately before inserting the block needle. The anesthetist and anesthesia assistant must double check the surgical site marking and the site and side of the block. So it is always very important to avoid wrong side block or wrong side surgeries. Thank you very much, and any questions I'm open to take. Thank you.